Primary assessment, the basics. We usually think about this as we learn about the ABCs of the primary assessment. And ideally, this is the primary assessment. You need to think about their LOC or level of consciousness, how they respond to you given the AVPU scale, when they respond to you, use an orientation scale. Now, if they find to be confused or disoriented, or in worst case, they're unresponsive, we would then move towards addressing and treating these life threats. Airway. It's important that you know when you need to use adjuncts and to clear an airway. This should take you no longer than a few seconds, as you need to now manage the patient's breathing. Their rate, rhythm, and quality is important to note, and any adventitious breath sounds. Treating a breathing issue would require you to give passive flow oxygen or positive pressure. Remember, there are other diagnostic equipment that we can use to determine breathing status, such as end-tidal CO2 or capnometry, and the pulse oximetry. Within that same 30-second glance, we also need to point at the circulation. This would be skin signs, a radial pulse or peripheral, versus a more central pulse, such as the carotid or femoral. And in worst cases, if we're unattainable to get a pulse rate, quality, and rhythm that's palpable at a distal or peripheral avenue, still consider using the stethoscope to auscultate for heart sounds, as blood has to flow through those valves in order to hear the lub-dub sounds of valve closure. We move towards disability. This would be anything that the patient may suffer from, or anything that could be treated and isn't being treated could make the case worse. Hypoglycemia, a temperature, skin findings, you name it. It's also going to somebody that has home flow oxygen. They're already on a CPAP machine at home. They may have a wheelchair. E, get exposure to your patient. Get into an area that is accessible. Once you do, continue to then expose the patient so that you can do a further assessment. Now, the primary assessment may change given if it's a trauma patient. We may look for controlling gross exsanguination from arterial bleeding or the cab pneumonic in cardiac resuscitation. Nevertheless, the primary assessment, after determining the level of response, orientation, is to treat those life threats, to suction and provide management of the airway, to reestablish breathing, and to provide passive or positive pressure ventilation, and circulation, to maintain and establish that there is regular rate, rhythm, and quality to the heart rate. Now, I did show you a few different diagnostic equipments that we could use to assess their airway. You saw a laryngoscope blade. However, these would be more advanced things. But consider the pulse oximeter, your end-tidal capnography, your electrocardiogram, and the like, all to be part of that assessment in managing the primary assessment. So now your task is to look to see if you can find the life threat as you go on cases. A lot of times, what we forget is that we're not addressing A, B, and C on calls. We're just looking at a patient as we address the scene, as we address our patient. But take a look and see if they have open mouth breathing. Listen to hear if there's any gurgling or stridor. Watch the chest rise and fall as the patient is breathing. Is there accessory muscle use? Is there increased work of breathing? And is the rate faster or slower than normal? Reach for a pulse at the radial artery. Feel the skin temperature, color, and feel if there's any diaphoresis or if the skin is clammy. Note the rate, rhythm, and quality of the pulse. Look for any other types of signs to the skin that would identify any other types of hemodynamic unstability or alterations in hemostasis. As you determine those life threats, these need to be corrected before you move on to anything else. And it's the basic maneuvers that you can perform that will save a life.